So I'll do our intro for Dr. Adler this morning. As we all know, he is a professor in the division of pediatric gastroenterology here at the University of Michigan. He earned his MD degree at the University of South Florida College of Medicine and completed residency at Boston City Hospital and Boston Medical Center, and then practiced in academic general pediatrics for several years prior to training in pediatric gastroenterology here at University of Michigan, and has been here on since 2008. His clinical and research interest is in the care of children and adolescents with Crohn's disease and ulcerative colitis. And his research focuses on improving short and long-term outcomes and health-related quality of life for children with IBD. So looking forward to your talk this morning.
Thank you. Thank you, Nina, and thanks everybody for coming. I hope I did this right. Okay, very good. All right. Well, thanks for joining this morning. I'm looking forward to talking with you about everything that I've been doing over the past several years. I'm a pediatric gastroenterologist, so this is going to be a very, very narrow niche topic, but hopefully you'll see the importance of it. Let's see. No. I could just use the keyboard. Okay, very good. Thank you. Right, these are my disclosures, all of which are relevant to this talk and outline. So I'm going to talk about inflammatory bowel disease, which is a chronic condition of inflammation of the gut where the immune system attacks the gut. There's two main varieties: ulcerative colitis, which affects the colon or the large intestine, and Crohn's disease, which can affect any part of the gut from end to end. I'm going to focus mostly on Crohn's disease for this talk. This is data from two studies on the epidemiology of inflammatory bowel disease in pediatrics. This is data from the United States showing increased incidence. Every country that's looked at this, including countries that actually have national data, have shown a similar pattern of increasing incidence and then compounding prevalence. And the most recent data we have is up here. These are from two different studies, but it's going in that direction. And so these are not rare diseases anymore. The estimates are around 0.7 or 0.8% of the US population have inflammatory bowel disease. And in children, it's now about 1 out of 1,000 kids. So these aren't rare. And I see a lot of this. So Crohn's disease causes inflammation, like I was saying, any part of the gut, but it's through and through, from the inner lining to the outer lining of the gut. And that inflammation, when it gets really bad, it gets thickened and causes narrowing of the lumen or the space of the gut. And that can be, over time, the chronic inflammation can be replaced by collagen and scar tissue, which can cause blockages, narrowing and blockages, and cause bowel obstructions. And with ongoing inflammation in that wall, you can get a fistula, which is an opening from the gut to whatever is next to the gut. In this diagram, it's an abscess. The most common place for fistulas to show up is around the rectum, around the anus. This is an illustration, showing the anatomy of the rectum, the anus, these are skin tags, supposed to be skin tags, these lumps there. The sphincter muscle is a three-dimensional structure. It's actually a complex of muscles. And that's what these stripy things represent. And you could see these fistulas, which are holes from the gut to whatever is next to it, go right through the sphincter muscle. And you can imagine if it gets really bad, it can damage the sphincter muscle. And we all benefit from having a sphincter muscle, at least I hope we all do, because it really is helpful for continence and all of that. Fistulas can not only go to the skin, they can go to nowhere to create an abscess, which can be very painful. And they can also go to whatever structures are next to the bowel. You can get rectovaginal fistulas in girls, rectovesicular fistulas, the bladder in boys. And if the fistula goes the other way, you can cause infections of the bone, of osteomyelitis, of the coccyx. It can cause lots of misery. I'm going to go a little bit out of order, but talk about some of the studies that I and our group has been working on. And this is actually the latest data. We started some patient interviews as part of a study that I'm going to talk about later, but just to give context to how big a deal these things are, these are some quotes from our first interview. I never heard of fistula. I had no idea what this was. And this is somebody who had inflammatory bowel disease for a while and then developed a fistula. She's complaining about symptom. We've seen a doctor, we've gotten an MRI. Sometimes that's 2 or 3 months, delay. I'm a mom. I'm helpless. I can't do anything to fix this. And I'm going to just ballpark this at about $1,000 each time with this recurrence of fistula. And we have very good insurance. These are very impactful to patients, to families, both in terms of the physical consequences, the emotional consequences, and the financial consequences. So my interest in this actually started with really trying to understand these diseases. And I was seeing kids with fistulas in clinic all the time. And when you look at the data, the published data, these are supposed to be rare complications. This is an adult study that showed 6% of people develop perianal fistulas. This was a pediatric multi-center study that showed, over 10 years, 9% of kids develop fistulas, which is not what I was seeing in practice. And neither of those were population-based studies. This was a French national cohort study that showed that in children with Crohn's disease, 27% would develop perianal fistulas, which looks closer to what I was seeing in practice here. We're part of the Improve Care Now network, which is a national quality improvement collaborative of pediatric IBD centers around the U.S. There's a few centers outside the U.S. This has been going on since 2007. We joined in 2009. And as part of this group, we collect data prospectively on kids, and the physician classifies the disease phenotype and behavior and whether or not they have perianal disease. It's not granular data, but it's some data. So I got access to the data, and we looked at how often are kids developing these perianal fistulas. And this was the slide before said there were 109 centers. That's now, I forget how many there were back then. It was 60 or 80 centers or something like this. But you could see rising incidence. This is time after diagnosis in the x-axis, and you can see it's about 30% or so of kids develop perianal disease. Nothing like the 6% or 10% described in those previous studies. This is more aligned with that French study. And we saw disparities or differences in different groups of patients who develop fistulas more often than others. And this has been well described. The reason, the why, is a whole other discussion that I'm happy to talk about, but not going to get into that right now. So one of the first studies that I did when I came to join CHEAR was to work with Kevin Domkowski to try and develop a validated case definition for perianal fistulas in administrative claims data. Because that first study that I showed you of 6% of adults developing perianal fistulas, it wasn't based on any validated definitions, and I assumed that it was under reported. I used to have a slide, or I have a slide, I should have put it in here, of what our old paper billing forms looked like, and there wasn't perianal fistula, so I couldn't have actually checked it. I had to handwrite it in. So it may be for many reasons that it's not billed for. So I don't know, it does show up a little bit. Medical record evidence, claims evidence. This is what was recorded in the medical record. And you can see for perianal fistulas, for perianal abscesses, for all of the findings that they were more common in the medical record than showed up in claims. So we looked at a whole bunch of combinations of claims that I thought might sort of circumstantially be associated with perianal fistulas. And we looked at the combinations to see what combinations were most reliably predicted if a patient actually had perianal fistulas. And this was our key figure comparing sensitivity and specificity. And the best definition that we came up with, still not perfect, but had a sensitivity of 78%, a specificity of 98%. So a much better sensitivity without sacrificing much specificity compared to, this is just a single claim for perianal fistula for the medical records. And I should have said, we compared Medicaid data to medical record data at the U of M system. So how generalizable is this? There's a question, but this is at least the best that we have. So based on this information, then we could use, now that we have a definition, we could start to look at administrative claims data and do all kinds of other studies. So we did just that. We looked at Optum Insight, which is commercial claims data from the US, to look at among pediatric patients with Crohn's disease, how often do they develop perianal fistulas? And this was getting at my real question, which is, these are miserable disease complications. They're very difficult to treat. They come back frequently and come back with a vengeance and are more difficult to treat when they come back. So as a pediatrician, I know I'm a pediatric gastroenterologist, but I'm still a pediatrician. I'm really interested in prevention. And that's actually my underlying interest in all of this is, can we prevent perianal fistulas and other disease-related complications? So this study was aiming to look at that. How often does it happen? And other treatment patterns early in the course of the disease that are associated with a reduction in the development of perianal fistulas. So we used the commercial claims data. We identified all the patients in the database who had pediatric onset Crohn's disease and identify the ones who already had perianal fistulas at the time of diagnosis and excluded those because I wanted to look at among kids who don't yet have perianal fistulas, does early treatment reduce the risk of developing perianal fistulas? And so you can see in this data set of 2,200 kids, 8% had a perianal fistula at diagnosis and 19% developed later on. 27%, which is exactly the same number that was seen in that French study. So I feel like this sort of corroborates that finding on a large scale. And then we looked at the early introduction of steroid-sparing therapy, which is the biologics and mostly the anti-tumor necrosis factor medicines like infliximab and adalimumab, or the older immunomodulators, which is the thiopurines and methotrexate. And we looked at, did you start any of those medicines early or not? Because a lot of kids are not being treated with what we think of as standard of care medications. And then we did a propensity score matching to make sure we had kids with like characteristics that we were comparing to each other to see what the impact of early treatment was. So we have 972 kids treated with early steroid-sparing therapy, 972 not. I could talk about what early means later, but for the purposes of this study, early means before you develop the complication. And this is what we found. If you start steroid-sparing therapy early in the propensity score match cohort, there was about a 60% reduction in the hazard of, or the risk of later developing perianal fistulas. On the x-axis here is time from Crohn's disease diagnosis going forward. So, 1 year, 2 years. On the y-axis is the proportion of patients who have not yet developed perianal fistula among those who did not have perianal fistula at the time of diagnosis. So 60% reduction is in kids treated with any of those medicines. And if somebody was treated with both classes of medicines, the anti-TNF medicines plus the immunomodulators, then there it is, 80% reduction in the hazard of developing perianal fistula. I want to point out a couple of other things here is we did not actually find differences by race, at least by race as it's recorded in the Optum Insight database. There's lots of studies that have shown differences by race, and I think there's more to it. I personally don't think it's biologic, although I may not be in the majority opinion with that, but we did not find differences in race. We did find differences by education, and I don't have the data here, but if you look at the intersection of race and income, that's where we see actually the biggest differences. I was really gratified to see this study published. This was an adult study that used Optum Insight database to essentially replicate our study because, everything good comes from pediatrics. That's Dr. Meister's quote. So anyway, they did the same study we did. They took it a step further and they looked at both perianal fistulas, which are the most common form, and intra-abdominal fistulas, so bowel to bowel or bowel to whatever else in the abdomen, which are less common. And then they broke up the different types of medications, showing that it doesn't matter if you use anti-TNF medicines or anti-IL-23 medicines, or there are some differences, but mostly early treatment works. You treat the disease, you prevent it from getting worse. It's kind of a no-brainer. I just was pointing out the scale of their graph, which is not exactly the way I would do things. It could be a little misleading that way. But anyway, it was still a good study. But the question is, we all believe we should treat everybody well and treat everybody early, but are there some kids that are at greater risk of this than others? Are there some people we should be targeting for early therapy? And if the anti-TNF medicines really are the best, and they are the only ones that are approved by the FDA, but we can't treat everyone with them for insurance reasons and all kinds of other things. But are there certain kids we should be targeting with them for early? This was a single institution study we did here at the University of Michigan with our patient population, retrospective study. Some kids develop these skin tags or fissures, and we often think of those as, people often use the word heralding the development of a fistula. Now, do they precede the fistula? Do they not? It's not always been clear. So I worked with David Bloom is a pediatric radiologist here, and all of the kids at diagnosis get a MR enterography, and he went back and he reviewed the MRE on every single one of the children to see did they or did they not have a fistula. Because sometimes there's little tiny things and they may not have been commented on by the radiologist, but he classified them, so we excluded things that were questionable and included things that were tiny but real. And then Andrew Singer, who was a former fellow, is now faculty, reviewed all the charts to see who had skin tags, who had fissures. Sure, I couldn't find a picture on the internet. I attempted ChatGPT, but that's a fissure is a tear, and a skin tag is like just a growth of tissue. Everybody gets these from time to time, but in Crohn's disease, they are more dramatic. So he went through the charts to review to see who had skin tags, who had fissures, and the two of them were blinded to each other's findings. And then we looked to see, do skin tags and fissures actually sort of indicate increased risk of developing perianal disease in the kids who don't yet have perianal fistulas at diagnosis? And that's just what we found. We found a 5-fold increased risk of developing a perianal fistula in the kids who have skin tags or fissures if they did not yet have a fistula at diagnosis. Excuse me. Now we're getting into small sample size here. But if you focus on the dashed line is just the kids with perianal skin tags or fissures, and then look at treatment, like what happens with those kids. Small sample size, 55 kids. If they were treated early with an anti-TNF drug, that's associated with a 90% reduction in the risk of developing perianal fistulas in the kids who are at high risk of developing them. So this was really encouraging. But yet, of course, it's a small study. It's a single institution. It's a study. It's a retrospective study. So, we all know not to trust studies like this. So the next step we did is we got access to data from a large inception cohort. This was a multi-center study of children newly diagnosed with Crohn's disease and followed forward over time. We were not part of the study, so none of the kids in our study were part of this database. I wish we were part of the study, but we weren't. But it was a really good study, detailed characterization of the patients, and they did a lot of other stuff. But one thing they did not do is look at perianal disease. So we got access to the database. Sandy Kim, the senior author, she was part of the original study, so she was the one who was able to get us access to the data. And we, among all the kids in this database, in this inception cohort, we excluded the kids who already had perianal disease, like we had done previously, because I wanted to look at prevention. I wanted to know to see, can we actually, confirm or not that early treatment makes a difference. And there are these three main treatment classifications, the categories of medicines, the anti-TNF medicines, the immunomodulators, and then there's kids who are treated with neither. And so there was actually a previous study in this group that did a 3-way propensity score matched comparison of the three, which is not a normal statistical methodology. So it took a little while to figure out how to do this. Mosher was really helpful, and I know he consulted with his statistician colleagues to figure out how to do this. And there's this way to match them sort of like geometrically closest nearest neighbor in the triads of 3 kids with the same similar characteristics on the one from each of the 3 treatment groups. And that's what we did. So those are the kids that are included in the final study. So 149 in each of the 3 treatment groups. I should point out, by the way, that this is an area with very little research, which is part of the problem, is we don't know what we're doing. And it's such an important topic, and it's such an under-researched topic that Gut is the main journal in the top tier journal in our field. And so they published this. Again, it's a pediatric topic, but it's an important topic. So I was just really proud that this got published there. So anyway, we had 3 groups of patients who had similar characteristics to each other, that they were matched with one another. And then we looked at the early treatment and the implications of them. And we found essentially the same thing as the other studies. They had scheduled 6-month visits, so that's what we have data for. So I don't know what happened between visits, but this is the data. If you're treated early with anti-TNF medication compared to immunomodulators and compared to neither, there was a decreased development of perianal fistulas in the subsequent, whatever it was, 3 years among the kids who did not yet have them. The other thing I want to point out is those perianal lesions, the skin tags and fissures, they classified them, they characterized them at enrollment in this inception cohort. So we had data on this and we looked at it. And in fact, sure enough, fourfold increased risk of developing perianal fistulas if you had the skin tags or fissures. So now we looked at only those kids with the skin tags or fissures to see what happened with them. And same thing as our previous study, if they had perianal lesions, skin tags or fissures, then there was an increased risk of developing perianal fistulas. And in that group of patients who had the highest risk, we saw still a reduction in the risk of developing perianal fistulas if treated early with anti-TNF medicines, but not with the other groups. So about 95% reduction in risk if treated early with anti-TNF medicine. So this was really helpful, and it corroborated what we saw in the administrative claims database and what we saw in our retrospective single center cohort. So I feel like this really made the point that these things are preventable if we treat kids early, if we treat them well. And hopefully this will help not just with how we think about treating, but also with insurance companies approving these medications, because that's an ongoing struggle.
In some of the figures that you showed, the ones receiving these treatments were experiencing the fistulas later, but they were rising over time. So is this just bringing a shift in when it occurs, but they'll get there eventually?
It's a really good question. I'm not sure how to definitively answer it, but if we look not just at the hazard ratio and the shift over time, but we've looked at like this one here is so the previous one was hazard ratio, which is time to event. This one here is like the cumulative number, the odds ratio, the cumulative number of people who developed perianal fistulas by 3 years. So at least as of that time frame, we've reduced the total number of people who develop perianal fistulas. Now, is this durable? I don't know. I'm actually going to talk about treatment durability, and I suspect this has more to do with treatment durability than it does with the disease itself. That if you keep treating it, you keep preventing it. But I don't know how to actually prove that unless we have really, really long-term follow-up, which we don't yet have.
And the longer you're on these treatments, if one looks, we're all bombarded by these TV commercials and goes by and says what all the complications are. What are the complications with chronic use over time?
Yeah, that's a really, really important question. It's a question that every parent wants to know. Immune suppression carries risk. There's risks of infections. There's risks of malignancy. What we know about this is the cumulative, when you look at the thiopurines, that's one of the older classes of medicines, the cumulative risk of lymphoma increases with the use of those drugs. And with certain cancers, not lymphoma, but with skin cancer, that risk persists even after you stop the drugs. That's not the case with the anti-TNF drugs. There is in some studies, a slight increased risk of lymphoma. In the larger population-based studies, it's the same risk as the background population. So for lymphoma, it doesn't appear to be a big problem. Skin cancer, though, it is. So we counsel everybody on wearing sunscreen, doing everything you can do to prevent skin cancer. Cervical cancer is also increased risk with these drugs. So of course, we talk about HPV vaccination. But it all comes down to the weighing the risk of the treatment, the risk of the disease, and the risk of the disease in this case is much higher than the risk of the treatment, at least with our newer treatments. The older treatments, that's, I think, a bigger question. Yeah, thank you. So this is about identifying kids who are at risk and trying to reduce the risk of developing these disease complications. I want to shift gears now and talk about persistence, longevity, efficacy of therapy. The BISCUIT study the group voted on the name. It stands for Biologic Discontinuation Study. It is a study that we did with a subgroup of centers from the Improved Care Now network. So we have prospectively collected data from each of the sites that's in the Improved Care Now registry, but it doesn't include all the granular information that we want. So each of these sites did medical record review to supplement, because we were interested in finding out what's the real longevity of therapy and what are the predictors, and are there treatment patterns that are associated with longer persistence of therapy. And a little background to this is there's a growing number, we see the commercials all the time, there's a growing number of biologic therapies available for treating Crohn's disease and ulcerative colitis. To date, only two, well, now a third, are approved for the use in pediatric inflammatory bowel disease, infliximab, adalimumab, and just recently golimumab was approved after all of these studies, so it's not really included in these. But as you'll see, kids stay on these drugs for a time and then stop them and move on to another one and then move on to another one. We do have a risk of not only running out of the approved medicines, but running out of medicines in general for treating these diseases. And these are chronic diseases without a cure, and until somebody comes up with a better idea, it's lifelong therapy. So from these 7 centers, we used the Improved Care Now data. We supplemented with retrospective medical record review. We had 823 patients. These are the patient characteristics. And this is the treatment pattern. So 86% of these kids, and I think this was over a 10-year window that we looked at, 86% of the kids were treated with a biologic medicine, most of which was the anti-TNF medicines, infliximab and adalimumab. And among them, 2/3 of them were started on that biologic medicine within 90 days of diagnosis. And this is just a list of all the other meds that they were treated on early in the course of the disease within 90 days and total over time. Excuse me. But what I wanted to show you is, sorry. Excuse me, of how many kids are cycling through these medicines. If you look at all the kids treated with a biologic, about 30% of them on the right-hand side discontinue their first biologic and move on to something else. Of those, 36% stop their second biologic and move on to something else. Of those, 25% move on to stop their third biologic, and 36% stop their fourth biologic. And we're already getting into territory where we have fewer and fewer medications, Toby.
I was just going to ask, so I'm drawing analogies to asthma in my head.
Of course.
Is the reason for discontinuation a disease-related reason, like this is no longer working for me, or is it a therapy-associated reason? I'm getting a side effect, or is it an insurance, like they won't let me have it anymore?
I'll show you the data in just a moment, because that really is the question. What's going on? Why are they stopping? And what can we do about it? Because we really want to keep these diseases under control. So in summary of these kids, by the end of their observation period, which was either the study ended or they transferred to the adult world, 1 out of 12 of them had already been on 3+ biologic medications. At least as of this study, there were only 2 approved. So what was the reason for discontinuing? This is the breakdown, and this is the piece that came from medical record review. So as you can imagine, it's not completely documented, and there's holes in the data, and there's ambiguous reports and stuff. But adverse events was the most common reason. Insurance problems, contrary to my hypothesis, was the least common reason. And then secondary loss of responses, the drug initially worked and then it stopped working. Primary non-responses, the drug never worked in the first place, but we did more digging. And of those that said primary non-response, about half of them actually did start to work and then didn't work well. And so then they moved on. And of the kids where there was an adverse event for the reason, this is the breakdown of the adverse events. 30%, I don't know, it wasn't really recorded in the record, but this is what we have. Excuse me. So reviewing these, it looks like, and these are the ones that are, at least in theory, potentially preventable reasons for discontinuing the drugs, which amounts to nearly half of them. We might be able to do something differently to prevent them from discontinuing this drug. Excuse me, because we have really good data on how to prevent the development of anti-drug antibodies, which makes the drug ineffective or makes you allergic to it. Secondary non-response, so I'll show you a little bit of data, is often from underdosing. Underdosing either because the physician's underdosing, they're not paying attention as the kid grows, and the insurance company won't approve an appropriate dose. So I think there's opportunities for improvement here. This is some more summaries of all. If somebody's not doing well, particularly if the drug was working and then it stopped working, the standard of care is to evaluate them and figure out why. Is this a problem with dosing? Is this the wrong drug, wrong mechanism of action? Did they develop strictures or other complications where the drugs won't work? So overall, 75% of kids had some sort of evaluation prior to stopping the drug. If they stopped the drug because the drug wasn't working, 90% had some sort of evaluation. But look at this. Of the kids who had the drug level measured, and not all of them did, and there's reasons for that, but of the kids who had the drug level measured prior to stopping, these are kids who did stop the drug, a third of them were on a completely ineffective dose. So there's no reason the drug would have worked. They should have had, at least, unless there was something else going on, should have had some dose escalation. 20% of them had a minimally effective dose and there was room to escalate. The 10 to 15 range is in the range where it's debatable. Some people feel that's fine, I don't want to go higher. Some people will go higher. Above 20, everyone agrees that should be an adequate trial. So, there looks like there's lots of opportunity. Possibly a quarter to a third of these kids are discontinued. I'm sorry, the data we have is about 30% or so are discontinuing each of these medications. Many of them were discontinued, at least apparently without an adequate trial of increasing dosing. And possibly half of them, or maybe more, might even be preventable, which I think is important when we have a long-term disease and we have very limited treatment options. So I'm going to shift gears and get back to talking about perianal disease, but talk a little bit more about how we treat perianal disease. This is a study called the CHEAR study. Samir is the genius who comes up with these clever acronyms, which was a multi-center, multidisciplinary collaboration between pediatric GI, pediatric surgery, pediatric infectious disease, and pediatric radiology at 7 centers. Really, the main focus of this study is antibiotic stewardship. As I'll show you, we lose a lot of antibiotics in taking care of kids with perianal disease. And a secondary goal of this was to try and figure out better patterns of treatment to get these fistulas to heal. So CHEAR, the name, is a clever acronym, but it's actually a physical thing. This drain here is called a ceton. Surgeons place this drain in there, and we recommend them to because it actually helps with healing. If you imagine you have a fistula and germs from the gut are going into the space, it creates an abscess. You might treat it with antibiotics or whatever you do. As it starts to heal, this end closes, this end heals up, and then the germs are trapped there and they grow and they create an abscess again, and it opens up again. And that's actually the history of fistulas. They come around, they close, they open, they close, they open, sort of forever. So the idea of the ceton is to actually keep this open to allow drainage. So as you're treating the disease, as you're treating the fistula, as you're treating the abscess, as you're treating the fistula, a new abscess does not develop. So that's what a ceton is. Excuse me. The background to why we did this study, and I think why it was funded, and maybe why the funding wasn't canceled, is this was all about antibiotic stewardship. This is the entire world literature. 3 studies, all very small studies looking at using 10 or 12 weeks of antibiotics versus placebo for people with perianal Crohn's disease. These were both done in the days before we had effective medicines. This was in addition to effective medicines, but this is the entire literature. We have no nuance of who needs less antibiotics, who needs more antibiotics, when you can stop the antibiotics, how much do the antibiotics even help with healing? This is actually all about symptoms. So that's it. So the aims of this, these are the aims of the study. I'm going to go through them, but I basically talked about it already. So the first part of this was really just to describe the landscape. So we used administrative claims data. This time we used the Meritive Market Scan, which is both commercial claims and Medicaid, and used somebody else's validated case definition for Crohn's disease and our case definition for perianal fistulas. We required 5 years of enrollment, 1 year before Crohn's diagnosis and 4 years afterwards, so that we could really see the use of these medications. And then we compared the people who did versus did not develop a perianal fistula. PFC is perianal fistula complication. We made up that abbreviation, but that's what we're calling it. So we compared the people who did and did not develop perianal disease. This is the flow chart. We wound up with almost 5,300 patients, divided 4,000 with commercial insurance, 1,200 with Medicaid. And then we compared the groups who did develop perianal fistula and did not. And in this cohort with this insurance, 17% developed perianal fistulas. We did not exclude the people who developed perianal fistulas at the time of diagnosis for this, because it wasn't about prevention. It was about how we use medications. I think we excluded people who had fistulas prior to diagnosis. I don't remember how many that was. But anyway, this is the baseline characteristics of the patient population. And of this whole population of patients, and this was up to age 21, 83% of them had at least one antibiotic. The number of prescriptions varied widely from 0 to 33 prescriptions of antibiotics within the 5-year study period. And if you compare the total days of antibiotics, that's the cumulative days for each prescription added up together, you can see if you have a perianal fistula, a median of 2 months of antibiotics. And if you didn't have a perianal fistula, a median of 1 month of antibiotics. So we're using a lot of antibiotics for these kids. We didn't distinguish the reason for prescribing. Like, I can't tell the difference in claims if this antibiotic was given for an ear infection or if it was given for an abscess. We just tallied all the antibiotics, but only the antibiotics that were plausibly usable for fistula. So we didn't include antibiotics that have nothing, work on some other area. If we looked at the different procedures people had, abscess, drainage, ceton placement, all of these other things, you can see of the kids who had perianal fistulas, every single one of these, there were more antibiotic use. So this is possibly just an indicator of disease severity. And we see by other measures, people with more severe disease wound up getting prescribed more antibiotics. And I should say these are claims data. So this is prescriptions filled, not prescriptions taken, because of course we don't know if people took them or not. This is a multivariate analysis, negative binomial regression with number of antibiotic days as the dependent variable and the independent variables on the column on the left. And this is just a forest plot visually depicting the exact same thing. But you could see kids with perianal fistulas have some of the highest, this is incident rate ratio on the x-axis, but the highest amount of antibiotic use. Other things where we know if you have an intra-abdominal abscess, you're going to have antibiotics, so that's not terribly surprising. And ostomy, which is where you have a bag, so the poop goes this way instead of down towards the rectum, which we also think of as an indicator of more severe disease. If you have an ostomy, you wind up with more antibiotics as well. It was interesting. We originally planned on doing this analysis of looking at early therapy. Does it change the use of antibiotics? And then we took it out of the paper because the paper was kind of getting long and it wasn't the main focus of the study. But the reviewers asked us, does early therapy change the antibiotic use? So we put it back in and resubmitted it. And this is what we found. Patients without perianal fistula, patients with perianal fistula. And in the column all the way on the left, I guess I can use a pointer. In the column all the way on the left are the classes of medications and if they did use them and they did not use them. And I forget the definition of early here. I think it was also 90 days. Did they start them in the first 90 days? And these are the forest plots of incident ratio. So more antibiotic use, less antibiotic use. If they did not have perianal fistula, if they did have perianal fistula. And you could see steroids, which we generally agree are the worst of treatment options because they have a ton of side effects, but they work fast and we sometimes still use them, probably more than we should. Whether you have perianal fistula or not, using steroids is associated with increased antibiotic use. But if you look at the other class of medications, particularly for the people with perianal fistulas, the anti-TNF medicines, which are the most effective group of medicines, there's actually no increase in antibiotic use. And this is claims. We don't have chart review. I don't have detailed data on these patients, but my interpretation of this, at least my suspicion from this, is these medicines work and therefore you don't actually need to use antibiotics as much. We need more investigation to actually answer the question. But this is at least the pattern that we see is more effective medicines are associated with less antibiotic use. This was AIM 1A is looking at administrative claims. AIM 1B is chart review, medical record review from these 7 centers. And we're just now beginning this. We finally have the data. I don't have any results yet. Tom, thank you very much, is helping with looking at these data. But we have about 200 kids. But I thought the one thing that was interesting, at least at a like very preliminary look at it, is 55% of these kids, the perianal fistula was found because they were symptomatic, but the rest of them, it was found incidentally, either on MRI, on scope, on physical exam. So perianal fistulas can be very painful. They can be extremely symptomatic, but they can also be asymptomatic. And you think, okay, no big deal, it's asymptomatic. But there's now a couple of studies that show what happens with those asymptomatic fistulas. If you don't control them early, they actually get much worse, and they have all kinds of, then they develop symptoms and complications and everything. So even asymptomatic fistulas matter. So AIM 2 is people's perspectives and how we're prescribing antibiotics. AIM 2A is the physicians, the clinicians, and AIM 2B is the parents. And all of this is very preliminary data. And you're seeing this for the first time. Nobody's seen this yet because I just looked at this yesterday. This is our pulling the first data from the physician survey. And what we did is this is physicians from each of the 7 centers, pediatrics, GI, pediatric surgery, pediatric infectious disease. We didn't survey the radiologists because they don't prescribe the antibiotics, but we've surveyed the people who are prescribing antibiotics to understand the perspectives on how they use it and how they treat in general. And we had a series of case vignettes of going from minimally symptomatic, nothing perianal disease to, like awful, terrible, and asked them, would you prescribe antibiotics? Which ones would you use and all that? So these are the people who responded to our first round of surveys. And the plan is to repeat this so that over the course of the study, because these people are also going to see the data that we learned from the study, like how people's practices or at least perspectives change. So in the first round of surveys, 80 PGI docs, 30 surgeons, and those are years in practice. And this was the first case. You have a patient who has an incidentally found completely asymptomatic perianal fistula. Would you treat them with antibiotics? 20% said yes. And these are the antibiotics they're using. Ciprofloxacin, metronidazole, augmentin. Of the people who give antibiotics, half of them would give 2 antibiotics at the same time. It is recommended in the guidelines based on 0 evidence, but there is a recommendation out there. And how long would you treat them for? It's all over the place. That arrow points to what remember those 3 studies studied 10 weeks or 12 weeks versus nothing. Nobody studied less, but everybody's giving less than that. What's the right thing to do? I don't know, but look who's doing all the prescribing. It's us. The pediatric GI docs are the ones using months of antibiotics, not the surgeons. The surgeons, which I think makes sense, they're draining the abscesses. They're putting on the cetons. They might give some antibiotics as a temporary treatment, but we're the ones giving these are weeks of antibiotics, the pediatric GI docs. Now, the data that we have on antibiotics are about symptom resolution. So how many of these kids are symptomatic, have ongoing symptoms? How many of them don't? I don't know. We have the data on that. Hopefully I'll get that eventually. But the reasons for all the long prescribing is a really big open question that we're hoping to answer. The second case was a perianal fistula, simple. So not branching, no abscess, just one fistula, and it's spontaneously draining. Would you give antibiotics? 60% said yes. And what are they giving? 40% of them are giving 2 antibiotics at a time. And how long do you give the antibiotics for? Until they have some sort of improvement as assessed by imaging, by physical exam, by symptoms, or by some fixed duration. I should have said that in the previous one. That's the fixed duration. The old studies were all based on symptoms. There's some studies that have looked at not antibiotics, but other medicines in terms of like, if you press on the fistula, does it hurt? If you press on the fistula, does drainage come out? Literally, that's the outcome measure they used for some of the old studies, which is a lousy outcome measure. We have really good studies to show that it totally doesn't correlate with healing. But in practice, people are still using that to decide when to stop the antibiotics.
How often are you seeing these patients in clinic?
That's a really good question. I wish we asked that in the survey. I think we should ask that in the next round of surveys. Me personally, I'll see them frequently until they're clearly getting better, and then I'll space out the visits, maybe monthly. I mean, if they're really symptomatic, I'll bring them in sooner, but I don't know what the right answer is. This is a hard one to do over telemedicine. Although if we're asking people verbally, what are your symptoms, that you can do over video. But if you have to actually look at it, and nobody likes having their bottom looked at. And this is I mean, we've talked about this before, like people's perspectives on perianal exams and how often should we be examining them. And I don't know the answer to this. I do have data that, I put in the extra slides at the end, that patient symptoms do not correlate at all with findings on exam. At all. It's a small study, but I'll show you at the end. I'll skip forward in a minute. Okay. Anyway, not to belabor the point, but and again, it's the GI docs, and this is the abscess physically on exam. Those are the things that hurt. And 3/4 use antibiotics, lots of antibiotics, mostly double antibiotics. For how long? Again, based on symptom resolution. And if it's for symptoms, maybe that is the right thing to do. Gary.
Why would someone not treat an abscess with antibiotics?
Well, this is a question that I think is really important because if you had an abscess anywhere else in the body, once you drain the abscess, you don't need antibiotics anymore. So I don't have the data yet, but is part of this, I will treat them until the abscess is drained. Maybe it is, but I don't know. I don't have that data yet. And one of the complicating factors here is you put that ceton in, the surgeon goes in and drains the thing, but these abscesses are sometimes loculated. There's multiple compartments, and sometimes you don't even know that you didn't get it fully drained until you do follow-up imaging. And we do follow-up imaging with MRIs, which are hard to schedule, and it takes months. I'm hoping that we'll eventually be able to do that with perineum ultrasound, so external ultrasound, not internal, but that has yet to be studied.
Yeah, I don't know if you're going to present this data, but like we also look to see, does antibiotic therapy help with healing?
Yes, thank you. So I didn't actually put it in here. So we had a poster at the last conference that we presented, just simply looking at time to healing and antibiotic use, and there was no association whatsoever. The best I can tell from the data that we have is this is really about symptomatic improvement, like helping patients feel better until you get this thing healed. It's not about healing, but nobody's looked at healing. The only 3 studies that looked at antibiotics looked at symptom resolution. There's not a single study out there that's looked at healing. So I'm hoping that we can answer that question. Thanks for reminding me. Yeah, again, it's the GI docs doing this, and that may or may not be right. I don't know. The next aim of this study was the patient surveys, and we saw these quotes already. And this is all from one person because we've only done 1 survey so far. We're just getting started. We have another one scheduled tomorrow. We have a bunch of them scheduled, and our goal is, I forget how many, 100 some odd surveys. So in the end, we'll have, hopefully we'll really see the themes of people's experiences with this. But this is about patient experience, about not just the use of antibiotics, but the use of these medicines and people's experience with it. And we have an add-on study I'll show you in just a moment that's more about the patient's experience as well. And this is it. This is the most recent study, and this is just launching. I think we just got an IRB approval last week, 2 weeks ago, whatever it was, that we're just getting set up for this. The EFFORT study, again, clever acronym. Samir came up with the acronym. This is about people's experience of perianal fistulas, both the patient and the family, but also the barriers to care and their experiences with the healthcare system. And I have 0 data because we're just starting, but the aims of the study, one is to describe the impact of perianal fistulizing complications of Crohn's disease on children and their families. And we're going to collect everything from the impact of symptoms, the impact of the perianal examinations, of going to the medical visits, the impact on the family, and the financial impact, including both the families and the physicians' perceptions of barriers to care, because I want to find out, I know what I experience with insurance companies, but I want to see what other people experience as well. Aim 2 is really to try and look at the treatment patterns to see if one pattern is associated with better healing than another pattern, more so than we're doing in the previous study. And aim 3 is, now this was the healing piece. This is the same 7 sites. We got another grant to do a different multi-center study on top of the previous one. So we already have the relationships, we already have the infrastructure, and thankfully we have some funding. So finally we're going to start doing this. I want to come back to the thank you slide in a second because I want to answer, sorry, this, the perianal symptoms. This is Blake Harden. He's a medical student who's been working with us, and he wants to go into pediatric surgery. We had a study of colonoscopies that we did for another reason, but in preparation for the colonoscopy, when we were recruiting the kids, we had them fill out a survey of their symptoms, which included asking them about perianal symptoms if they had any. And then during colonoscopy, when somebody is sedated, we always do a perianal exam, and it's more detailed than you would ever do in the clinic. And so we had him review the 2 sets of data. Well, actually, he reviewed the perianal findings and exam, but he was blinded to the survey data, and then we compared them to one another. And you can see this is a really tiny study, 33 patients. But the presence or absence of perianal symptoms didn't predict the presence or absence of perianal findings. There were kids who had fistulas on exam and had no symptoms. There were kids who had anal discharge and had no fistula. So it really, I've suspected this for a long time, but we finally have data, nobody's looked at this before, that we can't rely on symptoms. So then what do you do? Because nobody wants their butt looked at with every single visit. And I understand that. And the docs don't want to do the perianal exam either. It goes both ways. But anyway, since there's so little data on this, I was really actually happy for Blake and really kind of surprised that it wound up on the cover of this is a Pediatric GI Society's journal, because it's answering a question that we've all sort of scratched our head about, but nobody knows. But this really does get at this question of like, how do we do a better job of taking care of these kids? Nobody wants their butt looked at all the time, but yet, if we don't have a biomarker for perianal fistulas and we don't have symptoms that are reliable, should we be looking? If the risk of developing perianal fistulas I thought was greatest in the first 6 months or a year, should we look all the time? But when we looked at the, Sarah Reeves would kill me for saying the epidemiology of, because it wasn't an epi study. But if you look at the incidence of perianal fistula in our network, it looks like a straight line going up, that the risk continues to increase over time. So I don't know the answer as to how often should we be examining kids. But for any pediatricians in the audience, I think if you suspect somebody if you wonder if someone might have Crohn's or not, I think a perianal exam is appropriate. I do not do a digital exam. I don't think there's any reason to put kids through that. The surgeons in my medical school who said only 2 reasons: if you don't have a finger or if they don't have an anus, they're wrong. It's very invasive. It's very traumatic. And when I tell kids that I'm going to do a perianal exam, first of all, I ask them and their parents' permission. If they're younger kids, I explain to them, this is a private part. Nobody should be looking at this except your doctor, and only if your parent's there or whoever their guardian is. And then I only look at the outside, and I tell them that. And I tell the parent I'm not going to do a digital exam because that's what the parent's worried about. But I think just looking for skin tags and fissures is actually quite helpful. And I did not put the gross pictures in here because this isn't a clinical talk. But anyway, I don't know how often we should be doing these exams, but I think it remains a big question. So I think I'm about out of time. Oh, I have a few more times. Let's go back to the thank you slide, because a lot of people were involved in doing all of this research. And I would thank every single one of them, but the list is too long. But we have a lot more work to do. And this is a former patient of mine. She's now an adult, and this was at a Crohn's and colitis fundraising walk. She has a permanent ostomy because of perianal disease. And her mom wrote that on her belly. And this picture is being used with permission. Actually, she told me, you better use it in talks. So ostomies, we use not infrequently, because if stool's not going through the rectum, then you have less inflammation. But sometimes you still can't get rid of them because it still doesn't fully heal. So anyway, thank you for your attention. I'm happy to take questions if you have any more.
So it's not about your data, but the 2 of you have worked together for a long time. And I suspect it was CHEAR that maybe facilitated that. Nice example.
Yeah.
How do you think that your practice, clinical practice, or thinking about these conditions has been affected by your collaboration in both directions?
Deeply. So I think it started, I think simultaneously, both us being in CHEAR, but also clinically, because we, GI and surgery, were trying to come up with some protocols for treating these kids. So just to get us on the same page and sitting around the table, several meetings and talking about how should we be treating these kids, I think it was really useful. I mean, I learned a lot from the surgeons. I think the surgeons learned from us. And that was just the beginning of it. Then we realized we got a lot of work to do because all of this is based on our opinions and our anecdotal experience. But I think working with Samir, I've learned a ton. I think obviously it's benefited my research career, but I think it's helped me in patient care and having some data to now talk with families and say, this is what we know, this is what we don't know, but this is our experience. And I think working together, both in the research, but also on the patient care side, has been tremendously beneficial. Yeah.
Yeah,
I
we
think they do.
actually started a joint clinic where we see the families together, because what was happening before was the gastroenterologist would speak with the family, and then they have a conversation, and then the family would speak with the surgeon, that we have a conversation, and then I would then reach out to the gastroenterologist about what they talked about. It was like this triangle that it was an inefficiency of care when like all three of us just need to be in the same room, have the conversation, and then we can make a decision right then and there because all of the stakeholders were present. And we just found that it was far easier to make decisions. If you're asking about the collaborative nature of CHEAR, I mean, I can't even begin to describe it to you. I've pretty much worked with like everyone here. I've published with Jeremy. I've published with Kyle. I've published with O and Ryan. I'm co-mentoring someone with Aaron Carlton. Many of my mentees I've worked with Gary Freed. I think I can't even express how thankful I am that I've found CHEAR and I was part of it.
Yeah, I was thinking more from the kind of the patient experience and communication.
I think
Is it more seamless, less contradictions? Does that translate into greater trust in the families in the care?
yes. And I think in a couple ways. One is when we see patients together, it's so much better. And people say that because they're hearing the same message from both of us, not something that was probably the same but slightly different and sounded different from two different people. So I think in that sense, seeing them together is great, but we can't see everybody together. The kids that I see in practice, talking with the families, I feel like this research has been very helpful. Collaborating with Samir has been very helpful because I can quote the data. I can say, we've done the study, we've seen this. And even if we haven't done the study, I know the literature probably way better than I would have had I been a clinician, not a researcher. And families appreciate it. And I'm not afraid to say, I don't know. And I think people appreciate that too. And I'll say, this is what we know. And this is my experience with this, but there's no data on it. And I really think that, I think one, families appreciate that, but I think two, we provide better care. Because we think about this a lot. Maybe that's a arrogant perspective, but my opinion is I think it's true. Yeah, well, thank you. And I'd like to do more. I think we actually need more multidisciplinary clinics. There's good evidence that it does lead to better care. It's just hard to pull it off.
And there are many barriers.
Yeah, many barriers.
It took us a year to set up the clinic because our departments couldn't even agree on like which clinic would house the conversation because the billing or whatever is generated through there.
Yeah. And the scheduling and the billing and the staffing and then getting our colleagues to refer their patients to us. I mean, we're not in the business of stealing the patients. This is a consultation service, or maybe just, to help with problems. But I don't have the bandwidth to see every single kid. and I want them to go back to their doc. So it's a little bit of a sort of a, I don't know, careful dance of, I'm here to help, but I'm not going to take away your patients. Yeah. Yeah. Thank you. Any other questions? Jessica.
Like you see when you're studying the antibiotic use, are you like primary care physicians, like do they usually give antibiotics to start or they just report it to you right away? Does that impact those numbers?
I don't know. In the survey, we're not surveying the primary care docs because there's a bazillion out there. In the claims data, the billing code data, in theory, we could answer the question of who's prescribing them. But in they call it the taxonomy code of like what type of physician, it's really messy when I started to look at it. It's like, it's actually hard to tell because it's not like a clean definition of this is a pediatrician, this is a pediatric gastroenterologist, this is an adult gastroenterologist. Because I think, and maybe somebody knows better than me, these are self-selected classifications. And an adult gastroenterologist who might also see kids might check off both boxes, or a pediatrician who also, or someone who works in the ER might also be listed as a pediatrician. So I think it's really hard to know who's primary care and who's not. I think it's an important question. I think it's an interesting question. And perhaps we can answer that question in the kids who are newly diagnosed. In a part of our questionnaire is about like, how did your pediatrician treat you prior to coming here? But I don't know the answer to that.